Hi everybody, and today we're going to be talking about the autonomic nervous system and how it innervates organs in the thorax, the abdomen, and the pelvis. So to get started, we're going to work with something that we know relatively well off the bat, and that's the spinal cord. So just to refresh everybody, we're going to draw a little cross-section, a little cartoon of the spinal cord here. Bear with me for a second while I connect up all the loose ends. Alright. So, spinal cord, we cut in cross-section here, primarily can be thought of as composed of gray matter and white matter. The gray matter makes this little kind of a butterfly-looking structure on the inside. And it's called gray matter because it's somewhat darker in appearance because it's made out of cell bodies, neuron cell bodies, and these guys are hanging out on the inside of the spinal cord surrounded by white matter, which is axons and their myelination that is surrounding it and traveling to and from the spinal cord. Here we've got the posterior or the dorsal horn, anterior or ventral horn, and these guys contain both sensory and motor activity. Now, just in case anyone hasn't covered this yet, the ventral or anterior horn contains motor cell bodies that innervate skeletal muscle. And these guys travel out through what's called the anterior root to reach the spinal nerve, where it comes together with this other branch we'll cover in a second. Now, once it gets here, it's going to travel for a little bit before branching off into two rami. Now, there's an anterior ramus that's carrying motor impulses to skeletal muscles of the torso and the limbs, and there's also a posterior ramus that's innervating the muscles of the back, the intrinsic muscles of the back, and that's how they get there. Now, just FYI, these guys are also known as lower motor neurons, and they're innervated by upper motor neurons that are traveling in the the lateral corticospinal tract that travels in the lateral white matter here, jumps off synapses, and then innervates the lower motor neurons. Likewise, we've got sensory neurons located here in the dorsal horn. But what's wacky about this is these are the second cell bodies in the chain. The first cell bodies in the sensory chain are actually located outside the spinal cord in what's referred to as a DRG or PRG, a posterior or dorsal root ganglion. Now, ganglion refers to any cell body outside the nervous system, or outside of the central nervous system. Big exception on that being the basal ganglia of the brain, which we're not even going to touch right here. And these guys send their axons out through what's referred to as a posterior root. And these travel alongside the somatomotor axons and travel through the posterior ramus and the anterior ramus, and these guys are bringing sensory information from the torso and the limbs, or the back to the dorsal root ganglion, and then this pseudo-unipolar axon sends another extension to the dorsal or posterior horn of the spinal cord right there. Now, I've got another video all together on the somatosensory system, so check it out if this is something that you're unfamiliar with or you need to know. But essentially, at this point, it can either synapse here and have this second-order cell decussate anteriorly and join what's called the ALS, the anterolateral system. And these fibers carry pain, temperature, and crude touch sensation, or it can pass through without synapsing and reach the dorsal columns, which carry vibration, proprioception, and fine touch to the central nervous system up high. We're not going to worry about that right now. That's just putting everything into perspective. Now, I'm going to draw in the rest of the outline here, covering the posterior ramus, the anterior ramus, and right here, the point where these guys fuse is referred to as a spinal nerve. So spinal nerves and the rami, posterior ramus, anterior ramus, are mixed. They carry both sensory and motor sensations, or sensory and motor input mostly. And then right here, we've got an anterior root This is strictly motor output from the spinal cord, and we have a posterior root. This is strictly sensory information from the periphery back to the central nervous system in the spinal cord. So we've got everything in perspective now. So let's talk autonomic nervous system. Now in the spinal cord, we're talking strictly about the sympathetic nervous system. The sympathetics are located right here in the intermedial lateral cell column. From T1 to L2. We get lower down, we have some parasympathetic neurons located from S2 to S4. Now, we'll get into the difference between sympathetics and parasympathetics in a little bit, but right now, any autonomics, sympathetics or parasympathetics, in the spinal cord are located in this intermedial lateral cell column. So these axons are going to send their outputs, which are visceromotor, motor to organs, through the anterior root, which is motor only, as you'll remember, gets to the spinal nerve, right here, and I've left this little area blank on purpose because these guys don't immediately jump onto a posterior or an anterior ramus. Instead, they do something a little wacky. They travel to a collection of cell bodies that are right alongside the spinal cord. And that's why these cell bodies, or ganglia, are referred to as paravertebral ganglia. So right here, paravertebral ganglia, and you may also have been used to hearing these referred to as the sympathetic chain. Same thing. And what's going on here is these presynaptic sympathetics from T1 to L2 are traveling through the spinal nerve, and they divert off the spinal nerve to reach the paravertebral ganglia, boom, right there. And as they do that, they travel through a little bridge. This is called a white ramus communicans, or communicating white branch. And it's white because all these presynaptic autonomic neurons are myelinated. Myelin allows the impulses along these axons to travel faster, and it appears a little bit whitish. Now this pathway, from IML to anterior root to spinal nerve to white ramus communicans to paravertebral ganglia, is true of every sympathetic input in the body. So this first step never varies. But at this point, it gets a little strange, because if it's meant to innervate a structure in the limbs or the torso, it's going to synapse with cell bodies located in the paravertebral ganglia, and these guys are going to then exit the paravertebral ganglia through another ramus right here. And this guy is referred to as a gray ramus, plural would be rami, gray ramus communicans. And it's gray because the postsynaptic autonomics are unmyelinated. They're not myelinated, so they actually appear, if you're very lucky in the growth slab, to be gray, or at least grayer than the white rami. These guys then join the spinal nerve, and they jump onto posterior rami or anterior rami. And what they do, once they get in both of those places, is follow the peripheral nerves out to their targets. And their targets are one of three things in the periphery. Sweat glands, referred to as pseudo, S-U-D-O, not P-S-U, pseudo-motor, and that's going to innervate sweat glands, makes you sweat. So your sympathetic inputs to the body cause you to sweat. It can also go to a rector pili. Those are the muscles that lift your hairs when you get a fright. That's referred to as pilomotor. And lastly, they can go to capillary sphincters that control the amount of blood flow that's actually going to different parts of your peripheral body, so your skin or your skeletal muscle. So these capillary sphincters are called vasomotor. So when you have input to the somatic body, which is the skin, skeletal muscles, from the sympathetic nervous system, it's going to cause you to sweat, have the hairs on the back of your neck or your arms stick up and open up the capillaries to the skeletal muscles that you're able to address a threat. So right there, That's what happens with the somatic targets. At this point, we're going to get a little fun. If the sympathetics are somewhere in the region of T1 to T5 in the spinal cord, they also are going to follow the same initial pathway from the IML out the anterior root, the spinal nerve, the white ramus communicans is always the same, etc., etc. But at this point, if they're going to the heart or the lungs, they can synapse with cells in the paravertebral ganglia. And these guys do not exit through a gray ramus. They don't even exit through a white ramus. They take off on their own. And they travel to reach the heart, which I will render in an incredibly anatomically realistic manner right here. And they also travel to the lungs, or more particularly, they're going to the bronchi and the smooth muscle that opens and closes the airway right there. So this postsynaptic sympathetic stretches from the paravertebral ganglia, the sympathetic chain, to reach the heart and the lungs of the bronchi. And this is what's referred to as a cardiopulmonary splanchnic. Now, the cardiopulmonary part makes sense, heart and lungs. Splanchnic refers to an autonomic nerve that's traveling on its own. It's not part of another nerve. It's not traveling to the anterior or posterior ramus. It's on its own. And that's how the thorax is innervated. Cardiopulmonary splanchnics are made of postsynaptic sympathetics coming from the paravertebral ganglia. Now, would be wonderful if that was all there was to it. But here's where it gets even more fun. If we're a little lower down, say in the region of T5 on down to L2, we're innervating abdominal pelvic viscera. Now these guys have the same initial steps, repeated after me if you can, IML to anterior root to spinal nerve to white ramus communicans, fun, fun, fun. But if they're going to the abdominal pelvic viscera, they do something a little odd. Instead of synapsing in the paravertebral ganglia, they pass through it without synapsing. And they travel towards the midline of the body, and they try and succeed in getting to a collection of cell bodies hanging out in front of our aorta and our vertebral column. And these are collectively known as prevertebral ganglia. Again, ganglia referring to a collection of cell bodies outside of the central nervous system. And here, this, I'm only showing one, but this actually happens all up and down the chain below kind of below about T5 or so. So depending on where these guys exit the spinal cord and the paravertebral ganglia, they have a little bit different names. From T5 to T9, we've got the greater thoracic splanchnic. From T10 and T11, the lesser thoracic splanchnic, and T12, the least thoracic splanchnic. Those are not as ironclad as they've been presented in some textbooks, so we're just going to refer to those as thoracic splanchnics right here. There's also lumbar splanchnics. And finally, sacral splanchnics. And if there's coccygeal splanchnics, we are not worried about them. So those guys all have in common this. They're extending without synapsing from the paravertebral ganglia, heading towards the midline to reach the area in front of the aorta and the vertebra, and they get to a prevertebral ganglia. We'll discuss these in a little more detail shortly, but these are named for the blood vessel or the structure nearby. So in front of the aorta, we've got the celiac artery, the superior mesenteric artery, and likewise we've got the celiac ganglion, superior mesenteric ganglion, and we'll do a little more detail on that in a second. What all of those guys have in common is once they reach that ganglia, the presynaptic synapse with their postsynaptic sympathetic cell, and these guys stretch out to reach their target organ. Now that target organ could be the liver, could be the pancreas, could be the prostate, could be the uterus. Doesn't really matter. The way they get there is not by traveling on their own. They jump onto nearby blood vessels extending from the aorta, mostly to get to those organs. So if you want to know what the sympathetic innervation to the gallbladder is, you don't have to list a lot of separate nerves. You just have to know it travels from the celiac ganglion along the common hepatic artery, branching into the proper hepatic artery, branching onto the right hepatic artery, branching onto the cystic artery. Now, if you're unfamiliar with the vasculature of the abdomen, and you need to be, I have another video devoted to arteries of the abdomen, so go check it out, enjoy it, absorb it, and get back to me. All right, now this schematic summarizes the activity of the sympathetic nervous system in the thorax, the abdomen, and the pelvis, and we'll go into a little more detail in the next section regarding how each organ at each level is innervated. All right, now we're going to take a look at the sympathetic nervous system and how it's laid out from cranial to caudal. So we've drawn a kind of an idealized little brain stem, spinal cord in here, and all along the side of it we've got the paravertebral ganglia running, as their name would suggest, alongside. Now, one thing I want to bring to your attention is that we've got the IML, intermedial lateral cell column, located from about T1 to L2. I'm going to draw in the column right there. And it's hanging out in between the anterior and posterior horns of the spinal cord, only at those levels. And they are going to send, as we saw in the just previous section, their presynaptic sympathetic axons out to the paravertebral ganglia by following white rami. So that's kind of what we're drawing in right here. So from T1 to L2 there are white rami, and then above and below that levels there are gray rami as things leave the spinal cord, but there are no white rami. These are the only places you have them, and this is bilateral, but I'm only drawing it on one side for clarity. One other thing is that as these guys enter the paravertebral ganglia, they're actually free to ascend and descend. So the chain, sometimes known as the sympathetic chain, is actually linked by axons running between these ganglia. They can synapse when they reach their target ganglion and then actually leave through gray rami to get to somatic activity. And the sympathetic chain extends all the way from the head, up here with the superior cervical ganglion, down to the base of the sacrum, which is called the ganglion impar. So by having these guys spread all the way up and down the vertebral column, it in effect kind of stretches the T1 to L2 region and allows it to cover the nerves that go out to the rest of the body. It's kind of like we took this and stretched it out. So things going to the head and the upper limb, and the thoracic viscera tend to be localized up here in the T1 to around T5 to T9 area. And then things going to the pelvic viscera and the lower limbs tend to be clustered down here in the L2 up to about T12 area. There's no hard and fast definition about where the thing stops and starts, but suffice to say, nothing that's going to the head and neck is going to be coming from this far down. Likewise, none of your pelvic viscera are going to get their inputs from T1. It's going to be things that are a little more local. All right, so first thing that we discussed was the sympathetics. Upon entering the sympathetic chain, can synapse, leave through gray rami, and go and innervate sweat glands, erector pili, and capillary sphincters. Another thing they can do is synapse inside. And these guys that are going to the heart and lungs are referred to as cardiopulmonary splanchnics. Now, just FYI, some of these guys actually do ascend to more superior parts of the sympathetic chain before synapsing and sending axons to the heart and lungs, but they come from the T1 area originally and before ascending. And I'll just draw these guys as a single stretch right here, going by the name cardiopulmonary splanchnic nerves. And as already mentioned, that's going to be innervating the heart, and the lungs, otherwise known as thoracic viscera, and since they're sympathetic, when they reach the heart, they're going to cause it to speed up. When they reach the bronchi, they're going to cause the smooth muscle in the bronchi to relax so that more air can flow. So sympathetic responses are going to allow us to address a threat pretty readily. All right, that's it for the thorax, more or less, until we get to the parasympathetics. Let's move on to the abdomen and pelvis. And they're generally getting their inputs from around the T5, T9, then T10, 11, and T12, and then lower down into the sympathetic chain. The first real cluster of those that we're going to see is from T5 to T9. We have nerves exit the sympathetic chain and bundle together to form the greater thoracic splanchnic nerve. And you'll notice this is colored in green because these guys do not actually synapse. The innervation going to abdominal pelvic organs from the sympathetics don't actually synapse in the chain, they pass through without synapsing, and that's going to form, in this case, the greater splanchnic nerve. And that's going to be, we'll call it T5 to T9. And then from T10 and 11, we get the not too creatively named lesser splanchnic nerve, and that's going to be T10, 11. And last, and by definition least, is the least splanchnic nerve. And he's coming from T12. Now, a lot of textbooks like to treat these as though they're fairly ironclad. T5 to T9 is greater splanchnic, etc. In reality, there's quite a bit of variability in this region. So this is commensurate with more Daly and Agor's clinical anatomy textbook, but just realize in reality there is variability and you want to maintain some mental flexibility about exactly which levels contribute to these nerves. Now, what are they doing? They're innervating abdominal viscera, and to do so, we need them to connect up with the abdominal aorta. So let's draw aorta in. Actually, black will be a little better to start with. And I have a whole video on branches of the abdominal aorta. If this is something you haven't covered yet, you might want to go check it out. But first, off the abdominal aorta, going to any of the organs, we've got the celiac artery, or celiac trunk right here, giving off the left gastric, splenic, and common hepatic. We could draw in the inferior phrenic artery just for kicks there. A little further down, we've got the artery to the midgut, the distal duodenum, distal pancreas, distal head of the pancreas, I should say, ileum jejunum, cecum appendix, ascending colon, transverse colon. This is the superior mesenteric artery. Then, off on either side, we've got a retroperitoneal renal artery on the left and right, getting to the kidney and the ureter, as well as some of the adrenal gland. Two little guys dropping off here, little in size but not little in effect. These are the gonadal arteries, going to the testes or the ovaries, depending on whether we're talking about a male or female. Then we've got the last unpaired vessel coming off the aorta. That is the inferior mesenteric artery going to the hindgut. So descending colon, sigmoid colon, rectum, etc. At that point, the aorta bifurcates to form a left and right common iliac artery. Alright, so that's abdominal aorta in a nutshell right there. We'll color him in quickly here. Alright, so question is, why have I spent all this time talking about the abdominal aorta when we're talking about the innervation of the organs? Reason is, these presynaptic sympathetic splanchnic nerves travel to the aorta and synapse with their postsynaptic ganglia that are located there. And those guys are known as the prevertebral ganglia, as we talked about previously. So let's color those guys in now in purple. Hanging out at the base of the celiac trunk is the celiac ganglion. superior mesenteric ganglion hanging out in front of the superior mesenteric artery, inferior mesenteric ganglion hanging out in front of the inferior mesenteric artery. Now that's all pretty standard. Come to a couple little guys here. The aortico-renals hanging out on either side by the renal. And then, in between the superior and inferior mesenteric, we've got a scattered collection of cell bodies. These postsynaptic sympathetic cell bodies are scattered in this area called the intermesenteric plexus with some axons up and down. Likewise, at the bifurcation of the aorta into the common iliacs, we've got what's referred to as a superior hypogastric plexus containing cell bodies. And then, if there's a superior, there's probably an inferior hypogastric plexus. And in fact, there's one on the left and the right. So these scattered cell bodies are called the prevertebral ganglia because they're hanging out in front of the aorta, which in turn is hanging out in front of the vertebra. And this is what these splanchnic nerves target. So here, greater splanchnic travels in and synapses with cell bodies in the celiac ganglia. Lesser thoracic splanchnic comes in, synapses with ganglia hanging out in the superior mesenteric and the aortico-renal ganglia. And the least splanchnic comes in and synapses with the cell bodies of the aortico-renal ganglia as well. Now, as before, we can treat this as though it's ironclad, and that's what I'm doing for the sake of simplicity, but there is some crosstalk here. There is some travel up and down. Not every single axon from the greater splanchnic has to go to the celiac and celiac alone. There's a little variability, but you can treat that as a pretty standard route that they're going to be taking. All right, so where do they project? Once they've synapsed, the postsynaptic sympathetics have to get to the target organs, and they do that in the simplest way possible. They jump onto a nearby vessel and get there. So if I wanted to get to the lesser curvature of the stomach, I could follow the left gastric, or I could jump on the common hepatic and follow it to the right gastric. Likewise, if I wanted to get to the liver, I'd jump onto the common hepatic, proper hepatic, and then to the right and left hepatic artery to get to the actual substance of the liver that needs to be supplied by the sympathetic nervous system. And we'll draw in the spleen's blood supply right there, along with any sympathetics traveling to it. Now, at the time these axons jump onto the vessel, we just refer to that as the splenic plexus, the right gastric plexus, or the left gastric plexus, or the common hepatic plexus. You just name the artery and you throw a plexus on there, and that includes the sympathetic blood innervation coming from the aorta. Likewise, anything to the midgut, jejunum, ileum, is going to travel on the superior mesenteric plexus, renal plexus, taking care of the kidneys right there. And then we'll come back to these guys in a minute because our greater, lesser, and least thoracic splanchnics have pretty much wound down. They're not contributing a whole lot to anything inferior to here. What we have to do for that is come back here to the paravertebral ganglia and pick up our lumbar splanchnics. Now, unlike the thoracics, these guys exit the lumbar levels of the paravertebral ganglia, and they don't really bundle together. They just kind of hang out individually, and these are the lumbar splanchnics. Likewise, we're going to have unbundled sacral splanchnics, and these guys just run from the paravertebral ganglia to the abdominal aorta, which in reality would be hanging out right about here. But for the purpose of this drawing, we'll stretch all the way over to here, and they're just going to jump onto the aorta and innervate nearby postsynaptic sympathetics. So they're running to prevertebral ganglia that happen to be nearby. Intermesenteric plexus, inferior mesenteric plexus, superior and inferior hypogastric plexi. So that's how these guys all receive their presynaptic sympathetics in green and then synapsing that will then send out postsynaptic sympathetics thereafter. Gonads are innervated by postsynaptics that travel down the gonadal artery, so the testes and ovary. Receive it that way. Inferior mesenteric, at least some of them, come from the lumbar and sacral splanchnics nearby, travel down to the hindgut organs. So inferior mesenteric plexus covers the descending colon, sigmoid colon, rectum, and then we'll talk a little bit more about this stretch in just a moment. What I'd like to do first is take a second and talk more about the parasympathetics and then come back to how these guys are involved and contribute to the innervation of each organ. Alright, so now we're going to complete our picture of the innervation of the thoracic, abdominal, and pelvic viscera with the autonomics by adding in parasympathetics, the other half of the autonomic nervous system. Presynaptic parasympathetics, unlike the sympathetics, which are in the spinal cord, exclusively have two locations. First is in the medulla. You've got a right and a left nucleus there, and this is the dorsal motor nucleus of the vagus, or dorsal motor nucleus of 10. Not to be confused with David Tennant. This is the vagus nerve, the 10th cranial nerve. And the right and left vagus nerves extend from the medulla down along the kind of the anterior region of the neck, and they reach the thoracic cavity, and there they're going to innervate the thoracic viscera. So they're coming in and supplying nerves to the heart and the lungs, particularly the bronchi, just as the sympathetics did, but their action is very different. Parasympathetics are what we would refer to as the innervation that wants you to rest and digest. So instead of causing the heart to beat faster, the parasympathetics will cause the heart to beat slower. Instead of opening your airway, parasympathetics are going to innervate the smooth muscle of your bronchi and cause them to constrict. Now, all autonomics exist with a 2-neuron chain from the central nervous system up to the periphery. So the second axon, or nerve in these chains is very short. The postsynaptic parasympathetic cell bodies are located in the wall of the organ that they innervate out here in the thorax, abdomen, and pelvis, and their postsynaptic axons are very short, just running to the immediate area. So postsynaptic parasympathetic axons are in the wall of the organ they innervate. That's the heart and the lungs. Let's add some abdominal organs in here. So we'll draw in the esophagus along with the stomach right there. And just for fun, we'll also draw in the liver over here. Now, hopefully, you guys all recognize the fact that this is not even close to being anatomically accurate in terms of location. This is just a schematic. And we'll draw in the gallbladder, pretty little green there. All right. Reason we did that is because the right and the left vagus nerves, once they're done with thoracic viscera, travel on the esophagus and in fact interdigitate with each other on the anterior aspect of the esophagus and also on the posterior aspect. Posterior, I'm going to draw in a little dashed line here. I think you get the idea. And on the anterior vagal trunk, which these are now called the anterior vagal trunk and posterior vagal trunk, it's going to travel on the anterior surface of the stomach and provide some of its innervation. Parasympathetics to the gut tube, of which the stomach is a part, increase the amount of peristalsis going on and increase the glandular, or in the stomach's case, acidic secretion, so that you're able to digest more. The anterior vagal trunk also spreads across the lesser omentum to reach the liver and the gallbladder. And it's going to cause them to become more active, cause the gallbladder to secrete, hopefully. And then postsynaptic parasympathetic cell bodies in the wall of each organ will make the final effect to get those organs working. All right, that's it for the anterior vagal trunk, but the posterior vagal trunk that has contributions from both the right and the left actually jumps down onto the celiac plexus. In reality, the stomach is hanging out right about there, so this is not a big jump. And the vagus, in addition to supplying the heart and lungs and the foregut organs, of which the stomach, liver, and gallbladder are part, also supplies the remaining foregut organs by traveling on the left gastric plexus, splenic plexus, and common hepatic plexus. And when it reaches, in this case, say, the liver through a different route, the gallbladder through a different route, the duodenum, the pancreas, it's going to synapse in the wall of each of those organs and send short postsynaptic parasympathetics to the actual smooth muscle that they're innervating. Likewise, vagus nerve is also innervation to the superior mesenteric plexus. So this will be the midgut organs. So distal duodenum, jejunum, ileum, ascending colon, say it with me now if you want to, cecum, appendix, transverse colon, all those guys. You've got branches of the vagus, and I'm only drawing one in here, but there's really many, many, many branches, jumping onto the blood supply, following it out to the organ, and synapsing in its wall, and then very short postsynaptic parasympathetics will cause increased peristalsis of the gut tube and increased glandular secretion. All right. Now, this is a point of disagreement with some text. For the purpose of simplicity, we're going to draw any vagal contributions to the renal and suprarenal regions in the ureter coming from the vagus. Just be aware there's some controversy there about exactly which levels contribute to the renal plexus. We'll just draw that in. Now, that's it for the vagus. It kind of dies off at the midgut, but we've still got the need for parasympathetic input all the way down here in the hindgut and the pelvic organs. Let's take care of that by drawing in the other part that contributes parasympathetics to the body. And that's down here in the sacral levels of the spinal cord. And that's going to be the S2, 3, and 4 spinal cord has its own intermedial lateral cell column, just like the sympathetics did. And it's going to send its axons out through the anterior rami of S2, 3, and 4. And just like the anterior rami, exit through the sacrum, which I'll draw a crummy little cartoon of right here. We have the anterior sacral foramina, 5 of them. Maybe looks a little like a manta ray, maybe not. And as the sacral anterior rami exit from S2, 3, and 4, these sacral contributions to the parasympathetics do the same. Now, once they're out, they jump off of the anterior rami and they travel on their own. What's the name that we give to any autonomic nerve traveling on its own? It's a splanchnic. In this case, we're going to call them pelvic splanchnics. And that's nice because the sacral splanchnics are sympathetic. S is for sacral, S is for sympathetic. Coming from the very similar area, though, we've got the parasympathetic contribution. P is for parasympathetic, and P is for pelvic splanchnics. Hooray. What these guys do is they jump into the closest autonomic structure nearby, and that happens to be the inferior hypogastric plexus. Once again, anatomically, the sacrum is hanging out boom, right behind there. I mean, it's right there. So these are not elongated strips of axons like I'm showing here. It's a schematic. I think we all get the idea there. And what's going to happen here is that these guys have to get to the inferior mesenteric, the intermesenteric, and superior hypogastric plexus. So they are going to, some of them, hang out here for a little bit, but a lot of them are going to ascend up the chain here of the prevertebral ganglia. This is happening bilaterally. We're just drawing sympathetics on one side and parasympathetics on the other. And then they're just going to jump onto the blood supply to that organ. So if we're getting to the testes or the ovary, these S2, 3, and 4s actually ascend all the way through the intermesenteric plexus, jump onto the gonadal artery before making it to the testy or the ovary, and then synapsing in its wall and sending a very short postsynaptic parasympathetic to the organ itself. Likewise, hindgut organs, S2, 3, and 4 parasympathetics jump onto the inferior mesenteric plexus hanging out on the inferior mesenteric artery, synapse in the wall of the descending colon, the sigmoid colon, the rectum, and travel to increase peristalsis, or in this case, going to increase tone in the rectum and cause defecation right there. And then the guys that hang out here and jump onto the superior hypogastric plexus, they've got a couple choices. They can ascend to these other structures. They can jump onto the iliac arteries and get to pelvic viscera by following its blood supply. But they can also hang out here in the inferior hypogastric plexus. And what the inferior hypogastric plexus is doing is pretty interesting. Because it's so low in the pelvis, and because the pelvic organs are actually hanging out directly in front of it, it can travel to those organs without jumping on a blood vessel at all. And what it does is it just travels in a cluster, in a sheet, to those deep pelvic organs. What are those deep pelvic organs? Well, they're going to be the rectum. We already said rectum gets some of its innervation from the inferior mesenteric plexus right there, but it's also going to get some coming from this direct sheet of parasympathetics traveling to it. And once they get there, they can synapse and increase tone in the rectum. But the other pelvic organs are hanging out just anterior to the rectum. What are they? Well, in women, we've got the uterus and the oviduct. If you're still following me along, you realize my artistic skills are somewhat limited, so not the world's greatest uterus, but it'll do the trick. Uterus and oviducts right here, not the ovaries. Ovaries are strictly from their plexus by way of their vessels, but the cervix, the uterus, and the oviduct are also receiving this sheet of parasympathetics running from the inferior hypogastric plexus. And what do we have in males? Instead of the uterus, we've got a prostate, and off of that we've got the seminal vesicles and the vas deferens, aka the ductus deferens. And likewise, if we're male, instead of having a uterus, we've got those guys, and you've got a sheet of autonomic fibers running across it. And in both males and females, hanging out anterior to all of that, we've got the urinary bladder. And once this sheet of autonomic fibers crosses the uterus or the prostate, they roll onto the urinary bladder, and everywhere along the way, it's innervating these target organs by synapsing with short post-synaptic parasympathetics in the actual wall of the organ itself. Parasympathetic is going to increase urinary kind of drive, going to increase tone of the bladder. And right here, these guys are just named for what they're near. So we've got the rectal plexus, the uterovaginal plexus, the prostatic plexus, and the vesicular plexus. And during pelvic surgery, it's very important to try to minimize trauma to these guys because they will result in dysfunction of the rectum, the bladder, causing urinary or rectal incontinence, sexual dysfunction caused by abnormal functioning of the uterus, the oviducts, and the prostatic viscera right there. So bad news, you want to stay away from those if you can. And let's fill in a little something we didn't talk about before, is these guys don't only have parasympathetic innervation, they have sympathetic innervation, and they get it through the inferior hypogastric plexus. These sacral splanchnics that jump into it synapse with the cell bodies there. And again, they can ascend a little bit and travel out along the common iliac to the pelvic viscera that way, but they also have the option of jumping straight to these organs, as did the parasympathetics. So we're going to color in here the fact that these rectal plexus, uterovaginal plexus, prostatic plexus, and vesical plexus are not strictly parasympathetic. They contain presynaptic parasympathetics and postsynaptic sympathetics. Again, this is bilateral, so really we just kind of fuse this schematic and have it happening bilaterally that way. And that pretty much takes care of the innervation of the pelvic, abdominal, thoracic viscera. There is one exception I want to bring to your attention, and that's hanging out on the very top of the kidney. We've got the adrenal gland, aka the suprarenal gland. Suprarenal gland dumps epinephrine into the bloodstream to reach the heart so that we can have a sympathetic reaction. We can have the heart rate speed up, our whole body get ready for a flight or fight reaction. Now, the presynaptic to postsynaptic neurotransmitter in this system is always acetylcholine. So presynaptic sympathetics to postsynaptic sympathetics, acetylcholine is the neurotransmitter that's released to trigger depolarization there. Same deal with parasympathetics. Pre to post is acetylcholine. But parasympathetics, postsynaptic to target organ is also acetylcholine. So cholinergic outputs right there. But sympathetics, innervating the organs, their postsynaptic to target organ neurotransmitter is epinephrine, norepinephrine, aka it used to be called adrenaline. And your adrenal gland is also releasing adrenaline. That's because your adrenal gland's medulla is essentially a prevertebral ganglia that, instead of hanging out in front of the aorta, migrated into the cortex of the adrenal gland. So sympathetics travel into it, travel through the celiac plexus or right off the aorta or through the renal plexus and get here, and they synapse with these postsynaptic sympathetics right here, also known as chromaffin cells, and instead of having an axon, these guys just dump acetylcholine into the bloodstream. So instead of synapsing with the target organ, they dump it into a nearby venule, which then makes it to the heart, pumps it all over the body. That's one quick exception I wanted to make sure everybody was aware of. Last thing, I swear, is that in addition to the sympathetics and parasympathetics contribution to the autonomic nervous system, we've got a massive amount of sensory axons traveling from the organs back to the central nervous system. In fact, there's generally more sensory or viscerosensory axons than there are visceromotor axons. Now, if I've got ischemia of the heart, that's going to be considered a painful stimulus. Painful stimuli from the thoracic, abdominal, and several pelvic organs travel back to the central nervous system by jumping on their sympathetic innervation. So they're not sympathetics, but they are piggybacking retrograde on the sympathetics to reach the central nervous system, where they're then going to ascend and tell the brain that the heart's in trouble. The heart's got ischemia. Likewise, ischemia or toxins or other painful stimuli, especially stretch in the gut, is going to jump on the sympathetic innervation. So in the case of the stomach, we've got that coming from the splenic, the common hepatic, and the left gastric artery and their plexi right there. So these guys will jump onto the sympathetic innervation, back up the thoracic splanchnics to reach the sympathetic chain, and thereafter the IML. Actually, pardon me, they don't reach the IML, they just travel into the spinal cord at the same level that they were supplied sympathetics from, and then up to the brain to let the brain know that something's going on with the stomach. Now that's painful stimuli. Non-painful, reflexive stimuli, such as the heart beats and it stretches a little. Non-painful stimuli or reflexive stimuli from the thorax and abdomen and pelvis, most of the pelvis, travels along the parasympathetics to get where it's going. Likewise, stomach secretes, normal activity, it's peristalsing, there's a little stretch but not painful. That's going to jump onto the parasympathetic innervation of that organ to reach the central nervous system. So, in the thorax, the abdomen, and the upper pelvis, painful stimuli to the organ travel on sympathetics to get to the central nervous system. Non-painful stimuli travel on parasympathetics to update the CNS about what's going on. The only exception to that, and I'm sorry, there has to be an exception, is that in the pelvis, some of the organs are covered by the peritoneal lining. So if I've got a bladder here, the peritoneal lining covers part of it, but some of it's existing below that. Above the peritoneal linings, the upper part of the urinary bladder, the upper part of the fundus of the uterus, and the upper part of the rectum that are covered by peritoneum have the exact same setup. So upper pelvis, visceral pain follows sympathetics retrograde back to the spinal cord to get where they're going to be able to tell the brain that something's going wrong. Non-pain or reflexive activity of these pelvic organs will update the central nervous system by jumping onto their parasympathetic innervation and then back up there. But the part of the pelvis that's below the peritoneum, we'll call this the lower pelvis out of laziness, jumps onto the parasympathetics for both painful and non-painful stimuli. So the very lowest part of my rectum, my prostate, not necessarily mine, but a prostate, and the lower part of the bladder, should there be ischemic damage, overstretch, infection, something that's very painful or is perceived as painful by these organs that are below the peritoneal lining, will tell the brain about that by following the parasympathetics back. If everything's hunky-dory and they're just doing their job, it'll tell the central nervous system that by following the pelvic splanchnics back as well. All right, so that's the setup with visceral pain, visceral non-pain, or reflexive stimuli, and their relationship to the sympathetics and parasympathetics. I hope this has been somewhat illuminating, and happy studying.